Black Nurses Association and one of 3 chapters in South Carolina. Our chapter's strategic priorities are leadership development, mentoring, and advocacy. We're pleased that you are joining us for part 1 of a 3-part discussion on maternal mortality. Does race matter? And yes, race does matter. Before we begin to address any health issue, we really need to understand the impact and burden of that issue on our community, and therefore need to understand the data. At this time, I'd like to introduce this evening's speaker, who will help us explore and unpack maternal mortality data in South Carolina from a health disparities lens. Portavia Featherstone is a maternal and child health and WIC epidemiologist at the South Carolina Department of Health and Environmental Control. She has an undergraduate degree in biology and received her Master of Science in Public Health degree in epidemiology from the University of South Carolina in 2015, where she studied geographic access to health services and its impact on infant mortality and very low birth weight infants in South Carolina. Ms. Featherstone has received training in applied epidemiology methods at national training programs and conferences, and has presented on topics ranging from teen pregnancy, racial disparities in birth outcomes, and fruit and vegetable consumption in children receiving WIC. As an epidemiologist, Ms. Featherstone supports maternal and child health programs, including WIC and maternal morbidity and mortality review. Please welcome tonight's speaker, Portavia Featherstone.
Hi, good evening, everyone. Can everyone hear me okay?
Yes.
Okay. Yes, thank you, Ms. Davis, for the introduction. Again, I'm Portavia Featherstone from the South Carolina Department of Health and Environmental Control. As Ms. Davis mentioned, I'm an epidemiologist there, and I've been with DHEC for about 5 years, and I've been doing this work with maternal mortality for the past 2.5 years. So we'll go ahead and get started with tonight's presentation. Go ahead and share my screen. All right. So tonight we will discuss South Carolina's maternal mortality data. So we'll essentially give an overview. Before we get into the data, we have to provide background information just to provide some context as to what we're showing. There will be quite a few definitions that will be discussed, several data sources, and we'll just build our way into the data. First, we would like to acknowledge the Centers for Disease Control and Prevention, as well as the CDC Foundation and consulting staff for highlighting the work of the maternal mortality review committees. So for the past 3 years, they have really rallied the states around this issue, and they've coordinated conferences and trainings and webinars, as well as offered monthly office hours and TA. So we'll get into a couple of their reports that the CDC has produced on this topic, but I just wanted to say that they have been tremendous in the support that they've provided. My video is not, I don't have my video live, but this is just so you all know who I am. Again, Ms. Davis presented on the same information, and I provide analytic support to the Maternal Mortality and Morbidity Review Committee for South Carolina, the MCH or Maternal and Child Health Bureau, as well as the South Carolina WIC program. So what is the mission of the Maternal Mortality Review Committee, or in short, the MMRC? So the overarching mission is to increase awareness of the issues surrounding pregnancy-related death and to promote change among individuals, the healthcare systems, and communities in order to reduce the number of deaths. And I have a few words highlighted here that we will really discuss and go into detail later. One being pregnancy-related death. That is a specific, there's a specific definition for this word that's different from a maternal death. We'll also get into how through the MMRCs change can be promoted, as well as some of those individual healthcare systems and community factors. So there are several national efforts underway So the US has one of the highest rates of maternal mortality in the developed world. So the CDC just recently published, I believe at the beginning of 2020, the 2018 maternal death rate, which was 17.4 deaths for every 100,000 live births. CDC has not produced this metric since 2007 due to some coding issues related to the death certificate. We will talk about that a little bit later also. But we do know that the United States have one of the higher rates as compared to other developed nations. So the Prevention of Maternal Mortality Deaths Act was passed in 2018, which was an amendment to the Public Health Service Act. So in short, this act established and supported state MMRCs to review every pregnancy-related or pregnancy-associated death and to develop those recommendations for how to prevent future maternal deaths. This allowed federal funding to be allotted to states and jurisdictions to continue this work. Secondly, we have the Maternal Mortality Review Information Application. For those who are doing this work, we call it MARIA. In short, this is a CDC-developed data entry system that allows states and jurisdictions to manage their data. You have nurse abstractors that will, once we're notified of notified of a maternal death, the nurse abstractor will go into the system and pull information from the medical record, from the autopsy report, from the coronary's report, as well as family interviews. So there are a ton of information that is gleaned from the patient's record that is entered into the data entry system. Nearly 50 states and jurisdictions have a maternal mortality review committee. So this is not just for the state or at the state level. There are sometimes city review committees, maybe New York City, they may have a review committee. In some instances, there may be a multi-state committee, but this number is growing. I'm not sure in total how many there are, but I do know that within the past 2 years, that number has gone from 34 states and jurisdictions to 50. And then lastly, we have the AIM initiative, which is the Alliance for Innovation on Maternal Health. This is a national alliance to promote safe maternity care, to reduce maternal mortality and severe maternal morbidity through maternal safety bundles and quality improvement initiatives. So there are 3 major data sources for maternal death or pregnancy-related data. I'm sure that's probably very confusing given that all 3 originate from the CDC. So first we have the National Center for Health Statistics, which focuses primarily on the death certificate as the source of data. The death certificate relies on ICD-10 codes that are input into the system, and it covers a mother who has died during pregnancy through 42 days out postpartum or 6 weeks postpartum. And so this is the rate that has not been produced since 2007, but the CDC just recently resumed the publication of this statistic. So in the year 2018, that statistic again is 17.4 maternal deaths per 100,000 live births. But again, that's only during pregnancy or those deaths that occurred during pregnancy out to 6 weeks postpartum. This is really, this data source is really good for showing those national trends and to provide a basis for international comparison. So this is how we see how the United States compare to other developed countries. Secondly, in the middle, we have the pregnancy mortality surveillance system. So in addition to relying on death certificates, this data source links the death certificate to the fetal death and the birth certificate. So this is the advantage of doing that is that you can really validate that death. We'll get into that just a little bit later, but for instance, when we're relying on the death certificate alone, there could be instances where false positives are generated, such as an 85-year-old pregnant woman. Because the pregnancy checkbox being checked, that death will be pulled into the pile of those women who died during pregnancy, although we know that that's a false positive. So with the pregnancy mortality surveillance system, they rely on the linked records, and they assess those pregnancies or those deaths that occur either during pregnancy or up to 1 year post-pregnancy. The source of classification, so the source of pregnancy relatedness, comes from medical epidemiologists. They have their own codes that they use. And the MMRCs use those same codes, so it is directly comparable. The definitions are the same between the PMSS system and maternal mortality review committees. So we focus on those pregnancy-associated deaths or pregnancy-related deaths, or in some cases, the determination or the pregnancy-relatedness cannot be determined. And because the classification or the time frame is different, the measure is different. So for both the PMSS and the MMRCs, the definition, the measure is the pregnancy-related mortality ratio. So the purpose of the pregnancy mortality surveillance system is to analyze those clinical factors that are associated with deaths, to publish that information that may lead to prevention strategies. And then lastly, we have the MMRCs, which has been recognized somewhat of a gold standard. Again, the MMRCs rely on the linked certificates, but in addition to that, information is gleaned from the medical records, social service records, the prenatal care record, hospitalization, autopsy, informing interviews. And so again, the definitions are the same as far as the time frame. The committee is multidisciplinary in nature. And again, the terms and the measure are both the same. However, the MMRCs understand the medical and non-medical contributors to the deaths. They're able to prioritize interventions that effectively reduce those maternal deaths. Here we're just outlining the strengths and the challenges to all three, but I'll just focus on the MMRCs. So the MMRC data can be the most accurate identification and comprehensive review of the deaths because we have access to so much information. And from that, it allows us to create those specific recommendations for prevention, which is informed by their local context. So the work of the MMRCs is cascading. So we see that, we're really starting at the outcome at the end, which are those deaths at the top of the pyramid. But what we want to do is back our way down this pyramid into the maternal morbidity resulting in a primary care visit. So through the elimination of preventable maternal deaths, we would like to reduce maternal morbidity and to improve population health for all women. So we can use hypertension as an example. I'm not clinical, but I think hypertension might fit here. So for instance, hypertension could be something that a mother prior to pregnancy or even during pregnancy could seek out her primary care physician for. However, if she does not have a primary care physician, it may progress to the point where she's needing to visit the ER for an issue that could have been taken care of through her primary care visit. And then if that progresses, and depending on the management of her hypertension, it may develop into another condition to where she's hospitalized. And then a hospitalization, her condition might be severe enough to where it becomes a severe maternal morbidity, and then a near miss, which is a severe maternal morbidity that could have led to her death. However, it was a near miss instead. So we really want to back down this pyramid by looking at the outcome or starting with the outcome. For the South Carolina Maternal Morbidity and Mortality Review Committee, there is an extra word there, morbidity, was first convened in 2016. Again, it is multidisciplinary in nature. So the review committee consists of specialists representing primary care, family medicine, nurse midwives or midwifery, anesthesia, maternal fetal medicine, law enforcement, substance abuse and treatment, behavioral health, psychiatry. There are a host of specialists that serve on the review committee to really enrich the conversation and determine what are the contributing factors and what led to the death of a mom. The committee decisions are documented for each case or each death that occurs in the state of South Carolina and for all review committees. And then the data is stored into the standardized database, which is Maria that I mentioned earlier. And this allows states to, for one, because it is standardized, states can then develop reports and compare their findings to other states. And that's the beauty in having a system that is standardized and that states and jurisdictions use all in the same. And then again, the South Carolina Maternal Review Committee focuses on preventability, which they all do, and the development of recommendations for action. And this is where we really want all of the reviews to go, is to really focus on preventability and the development of those recommendations. The goals for the review committee includes determining the annual number of maternal deaths that are related to pregnancy. To identify those trends and risk factors among pregnancy-related deaths. So those risk factors could be the lack of social support. It could be low food access. It may be poor management of hypertension. So the identification of those trends and risk factors, to develop actionable strategies for prevention and interventions, and then to disseminate and act on those findings. This is the scope of the South Carolina Review Committee. We see that we have those pregnancy-associated deaths in the larger gray circle. And then we have those pregnancy-related deaths in the smaller blue circle. But the focus of the review committees is really the preventable pregnancy-related deaths. So just some definitions. Pregnancy-associated deaths are those deaths that occur during pregnancy or within 1 year of the end of pregnancy from a cause that is not related to pregnancy. This can be a little bit confusing, but essentially what this means is that the woman or the mom just so happened to be pregnant when she died. So an example of this might be a car accident, or example of this could be potentially overdose. So some states decide if they want to review before the full committee deaths due to car accidents, deaths due to overdose or suicide or homicide. But in some cases, it's determined by the state if that meets the scope of their review. And then you have those pregnancy-related deaths. And this is the death of a woman during pregnancy or within 1 year of the end of pregnancy from a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy. So this, in essence, what this means is that pregnancy-related deaths are those that are causally related to pregnancy. So a question that is commonly asked within the review committee is, if she were not pregnant, would she have died? And sometimes that's pretty much that key question that kind of plays in the back of your mind to let you know if this death was in fact pregnancy related. So her pregnancy, would they have changed the outcome for her? MMRCs review and document their decision on pregnancy relatedness. And the 4 categories include pregnancy related and not associated. And again, that's that larger gray shaded area of the circle. I'm sorry, that's the blue shaded area of the circle. So that's the main section that we're really interested in so that we can determine preventable pregnancy related deaths. Then you have those pregnancy associated deaths, which is that larger circle. And that's where the majority, depending on the access that you have, maybe the majority of those cases fall within the pregnancy associated column, meaning the mother just happened to be pregnant when she died. And then some cases are not pregnancy related or pregnancy associated, and that could be those false positives. So if you're relying strictly on the pregnancy checkbox, you might have an 85-year-old pregnant woman where the checkbox was accidentally checked. And so that would be a false positive. And then those cases that are unable to be determined. So wasn't quite sure if it was pregnancy related or pregnancy associated. This is an example of the committee decisions form that we use for each case that is reviewed at each meeting. We see here that there is a section for pregnancy relatedness. Okay. There's a section here for pregnancy relatedness here where we can document those 4 classifications. Down below, we have the completeness of the record. So did we have access to all of the key information that we needed? Did we have access to the death certificate? Did we have access to hospitalizations? We have the underlying contributing, immediate, and other significant cause of death. I want to drop back down below here. So the purpose of the committee is not to change what is written on the death certificate. It's simply to document by the committee what the committee felt was the cause of her death based on the circumstantial information. And then we have other contributing factors such as obesity. So did obesity contribute to the death? Just in May of 2020, discrimination was added. We know that Black and other mothers, minority women, have higher rates of maternal mortality than other groups. And so in some cases, which we know through literature, that discrimination and racism is a factor in a lot of various health outcomes, maternal health being one. So discrimination was added to the committee decisions review form, where we actually have to talk about whether or not discrimination was a factor. Also, mental health conditions other than substance use disorder. And then secondly, substance use disorder. Also documentation of whether the death was a suicide or homicide, and the manner of death. And on the second page, we have preventability. We will discuss preventability. There are a lot of questions even still after we've done this for now 2-3 years. There's still a lot of questions surrounding preventability. So there are two questions actually on preventability. The first is, was this death preventable? And in some cases, it can be a little bit hard to determine yes or no. So there's a second preventability question, such as the chance to alter the outcome. So in other words, was there at least some chance to alter the outcome? Could something have been changed? Was there at least some chance of the death being averted by one or more reasonable factors to the patient, the family, provider, facility, the system, or the community? And if we answer some chance or good chance, then that is recoded as yes, it is preventable. And sometimes it just gives us a different way to think about, or the committee, a different way to think about preventability. And then lastly, we have those contributing factors. There are 5 levels of factors. We will discuss that a little bit later also. In addition to space for recommendations, the prevention level, as well as the impact of those recommendations if they were to be implemented. All right, so now we'll actually get into South Carolina's data from the maternal mortality review committees. This is the 2020 South Carolina MMR, or the Maternal Morbidity and Mortality Review Committee legislative brief. So South Carolina is mandated to provide a report and update to this legislature each year. This is the first year that we've used this design. So the last 2 years we had a different design. And now that we have access to more cases, we've been able to actually include data from the committee within the report. This is just a snapshot of the upper portion of the document. We essentially give background information on when the committee was convened, which was in 2016, also talks about the definition and the scope of the committee. And our vision, the vision of the MMRC, is to eliminate those preventable maternal deaths, to reduce maternal morbidities, and to improve population health for women of reproductive age in South Carolina. Across the United States, roughly 700 women die each year from the result of pregnancy or delivery complications. And we know that some groups of women experience this event at a much higher rate than other groups. Here we have an example of this. So between the years of 2014 and 2018, we've combined multiple years because statistically speaking, the numbers are small, even though we know that one death is too many. But to produce reliable estimates, we have to sometimes pool together multiple years. So we see here that between 2014 and 2018, there were 73 women who had died either during pregnancy or within 6 weeks of giving birth in South Carolina. And that produces a rate of 25.5 deaths per 100,000 live births. Just to provide some context, on average, South Carolina has about 57,000 births that occur in our state. So essentially, there are between 12 and 14 maternal deaths that occur each year in total. But what's alarming here is that we see a pretty large racial disparity. We see that this rate is 16.4 for white mothers and 43.3 for Black and other mothers. So that produces a disparity ratio of 2.6. So in other words, Black and other mothers or minority women are nearly 2.5 times or more than 2.5 times more likely to die from from a pregnancy-related cause or pregnancy-related issue. So the maternal mortality rate is over 2.5 times higher for minority women versus white mothers. In this graphic, we're showing the same information, but we're showing 3 time periods, so 3 5-year periods. So we see that in 2012 through 2016 for South Carolina, that rate has gone from 24 to 25.5 in this most recent 5-year period. For white moms, it's gone up from 14.8 down and then back up to 16.4. And then for Black and other mothers, it's gone from 41.9 up and then back down to 43.3. But we will say that there's a clear increase in the rate of maternal mortality for South Carolina overall, as well as for Black and other mothers. The same information is presented just a little bit differently. So instead, we have the bars representing the race, and we have the x-axis showing the time periods. And we can clearly see that, again, there is that racial disparity as shown by the green and the blue bar. So just to show you what that disparity is, it's a nearly 3-fold disparity in the first 5-year period, 2012 through 2016, nearly 3.5 disparity in the 2013-2017 period, and back down to a 2.6 or 2.5 disparity between 2014 and 2018. There are 6 key decisions that MMRCs make for each of the deaths that are reviewed. All MMRCs review these questions through the use of that committee decisions form that I showed earlier. So the first one is, was the death pregnancy related? What was the underlying cause of death? And I'm highlighting the 4 questions that we'll discuss in this presentation. Was the death preventable? What were the factors that contributed to the death? What are the recommendations and actions that address those contributing factors? And what is the anticipated impact of those actions if implemented? So the first question, was the death pregnancy related? South Carolina has found that since the review committee convened in 2016, that of the 27 total cases reviewed, now that's important, of those 27 cases reviewed, 74% of them were determined to be pregnancy related. Now, the reason I say that 27 total cases is important is that this does not include all cases that have occurred in the state since 2016. Now, just this year, July of 2020, South Carolina gained access through vital records. And what that does is that it helps us with case ascertainment. So before, and even currently still, maternal mortality is voluntarily reported in the state. So we do not perform abstraction unless we're notified first through secure means that a death has occurred. And so that normally happens when hospitals notify our secure email address that a death has occurred in their facility. But now that we have access to vital records, this will enhance the completeness of our records, and we'll have more cases that will be abstracted, and we can have a complete picture of those of those deaths that occurred at least since 2018. So, we're now 4 years out from 2016, and we do have quite a few cases to go back and review. So we've chosen to start with 2018 and work our way forward.
Portavia.
Mm-hmm.
This is Lisa. I was going to hold questions until the end, but we do have a question that's related to your previous slide.
Okay.
So I don't want to lose sight of this question and wait until the end. I think if you go back one slide,
One more.
It was,
Here.
I think it's that slide. And the question is, what accounted for the higher rates in the middle chart?
Yes. So the rate is a function of the number of deaths in the numerator, as well as the number of births in the denominator. So as far as what has happened here, so it's not necessarily that there were an increase in the number of maternal deaths per se, but the number of births in the state has actually gone down for both the white population as well as the Black population. And depending on how great of a change that is, combined with the number of deaths in the numerator, it can make this disparity increase or decrease. And so this is important when we talk about statistical reliability. And that's why it's important to really have a sufficient number of cases, because 1 and 2 and small incremental changes can really change that disparity or change any metric. So it is important because we still see that there is a disparity, and it's more than one-fold, it's more than two-fold, but it might not necessarily be related to such an increase or an alarming or substantial increase in one versus the other. It might be the underlying distribution of the births, or it could be 1 or 2 incremental changes in the number of deaths.
And we did have one more question, and it was, it is interesting that homicide is included given the fact that domestic violence is very high in South Carolina. Are other DV reports included for prevention measures?
Are other DV, I'm sorry.
Domestic violence reports.
Yes, could you repeat the last question? Are other
Domestic violence reports included for prevention measures?
I don't think so. So we are exploring more into the domestic violence and some of the other factors or the other causes of death or factors that contributed to the death. So domestic violence, homicide, suicide, overdose is one, and then also those car accidents. So right now, because we're, at least in the past, before July, we've really relied on voluntary reporting. And so in many of those cases, the cause of death have been clinical in nature, more clinical, as opposed to interpartner violence or some other causes of death. However, now that we have gained access to vital records, we can begin to see some of the emerging issues. Mental health is one, and we can begin to explore those in detail and really develop those recommendations for action.
Thank you.
Yes. Okay. Yeah, those are really great questions. Okay. What was the underlying cause of death? So far, again, we have to focus on the number of cases that have been reviewed. These are not complete. We've not reviewed all cases since 2016. So we've only reviewed 27 cases up until March of this year. So among those 27 cases that have been reviewed, 20 were determined to be pregnancy related. So among those pregnancy related cases, which is the focus of the MMRC's work, we see that a fourth of those, the cause of death or leading cause of death for a fourth of those were hemorrhage, and that was tied with infections as well. And then we see that cardiovascular and coronary conditions or heart disease, stroke were shown as the third leading cause of death, and so forth and so on. And so this really is a really great graphic to see what the issues are in our state. However, I will say that with updated data, and I've begun looking at the cases that we have reviewed this year, including those cases, and this is actually changing a little bit. So some states are in fact seeing hemorrhage as a leading cause of death. Some states are seeing cardiovascular and coronary conditions as a leading cause of death. But I will say what's key about this is these causes of death, they will vary. They have shown to vary or known to vary by race, ethnicity, by maternal age, as well as by the timing of the mother's death. So this is extremely interesting. Was the death preventable? More than half of pregnancy-related deaths that the committee has reviewed were determined to be preventable. And what that means is that there was at least some chance to alter the outcome. That's either by patient factors or family factors, provider factors, community or systems of care, also facility factors. And so that shows that half or more than half of these deaths are actually preventable, and that's really unfortunate. But this is where those committee recommendations will really serve the work of the maternal mortality review. And so once those recommendations have been formulated and really coded, we can produce something meaningful that can be shared back with the Perinatal Quality Collaborative or the South Carolina Birth Outcomes Initiative, BOI, some may know it as, can really begin to put those initiatives and activities in place so that we can really begin to reduce those preventable pregnancy-related deaths, because we know that not all pregnancy-related deaths are preventable. And then what factors contributed to pregnancy-related deaths? So we see that systems of care comes in at 20%. Systems of care includes, as an example, inadequate training, lack of staff or understaffing of facilities, care coordination, the absence of policies and procedures. These are examples of systems of care. And we see that in 20% of all pregnancy-related deaths, systems of care was a factor. So 1 in 5, nearly 1 in 5 cases. For providers, this might include delay in diagnosis, delay in effective treatment, missed diagnoses, could also be training. We see that again, a little bit more than 20% of all deaths, we found that the provider was a contributing factor, or there were provider level contributing factors. So patient and family is interesting. A lot of people ask questions about this. So 37% of those deaths, there were patient and family factors associated with that death. So those factors can include patient knowledge, could include compliance or adherence to treatment. It could be even lack of insurance. And we know that having that insurance is key and serves us well when it comes to having that primary care visit and not having to rely on the ER for things that can be managed in through our primary care provider. So we see that patient level and family factors were associated with 30% of those deaths. For facility, that might include, again, policies and procedures, hospital levels of care, as well as maybe having the appropriate equipment or supplies on hand. That was found in 16% of the cases. And then community factors is low, but we know that through social determinants of health that community factors actually contribute, is a larger contributor to pregnancy-related deaths. And those community factors could be having access. So access to medical care, having access to grocery stores, access to healthy and nutritious foods. We know that some places, in some areas of the state, and we know in other states as well, there are food deserts. And then there are food deserts on this side of town. It might be a food oasis on the other side of town. And so we know that actually community plays a larger role in pregnancy-related deaths than we realize. A lot of this is really based on the data that we have. And since most of it comes from a facility such as the medical records, such as coroner's office, many of the factors might be clinical in nature, or as much as could be documented by a physician or by a provider or a social worker. So on average in South Carolina, there were at least 5 contributing factors for every pregnancy-related death that were identified. And then we have the final 2 questions that we're not presenting our statewide data on, but we will present findings from the CDC report. And that includes the recommendations and actions that address those contributing factors, as well as the anticipated impact of those actions if they're implemented. So this is based on findings from the CDC Foundation's report from 9 maternal mortality review committees. So what are the recommendations and actions that address those contributing factors we just saw? So one might include improving training. In a lot of cases, in some of these cases, physician training comes up quite a bit. And so some of it is related to actually just improving training or having refreshers for the physicians on some of these issues. Also the enforcement of policies and procedures. Maybe the facility didn't have a hemorrhage cart or didn't have the supplies that they needed. And it could be related to the policies and procedure and not following or not complying with those policies and procedures. The adoption of the maternal levels of care, which would ensure appropriate level of care for the mothers. So in our state and most other places that have a perinatal, regionalized perinatal system, it's really focused on the infant and the infant's health, the infant's outcome. So we know in South Carolina, our regionalized perinatal system really focuses on those high-risk mothers and infants, but more so the high-risk infants. So those infants that are very low birth weight, those infants that are preterm or have severe birth defects, So South Carolina has begun discussion on developing the maternal levels of care that will focus on the mother's health as well. Also, the improvement in access to care, improving the patient-provider communication. We know that depending on some communities have a history of that lack of trust when it comes to patient and provider. And so we do know and have discussed how the committee has discussed how to improve, in some cases, the communication between the patient and provider. And then also improving patient management for those mental health conditions. We'll see a little bit in a couple of more slides later that mental health conditions is actually emerging as a contributing factor and even as a cause of death. And lastly, what is the anticipated impact of those actions if they were implemented? This pyramid actually helps us to prioritize and translate those recommendations to action. I can say that most of the discussion centers around at least the impact of those recommendations is more so small and medium in nature. So patient education, patient counseling, making sure that the patient is linked with the social worker or case manager. Also medium in nature could be clinical intervention and coordination of care. Again, South Carolina, through the work of the Birth Outcomes Initiative, has adopted the safety bundles, the safety bundles. One is the obstetric hemorrhage safety bundle, which allows those facilities to make sure that their medical supplies available and a response team available in case of a hemorrhage. And then also, I believe, obstetric hypertension. And then overall, this is a comprehensive strategy to reduce those maternal deaths that would incorporate multiple levels. The goal is to really get down to those social determinants of health. We know that's where a mother, or where we live, where we work, where we play, where we pray, where we worship, all those things have a factor. The social support that we receive, racism and discrimination, which is shown to be a factor. Stress, maternal stress. So we really want to get to those giant factors and implementing those actions so that they can have a larger effect. And lastly, we'll move into findings from the CDC multi-state reports. We'll dive a little bit more into some of the racial and ethnic disparities. In this first graphic, we're looking at the underlying cause of death by race and ethnicity. So we did see a similar chart earlier, but now this is broken out by race and ethnicity. So it's always great to see what it looks like, just to get an overview of the status of your state. But what's more important is to see who's affected by what. So we see that the non-Hispanic Black population is shown in the purple bar, and the non-Hispanic white population is shown in that pinkish or salmon colored bar. We see that for non-Hispanic Black mothers, that the top 3 leading causes of death, pregnancy-related death, included cardiovascular and coronary conditions such as heart disease and stroke, followed by, cardiomyopathy first, and then followed by those cardiovascular and coronary conditions, and then lastly, preeclampsia and eclampsia. And then if we look at the non-Hispanic white population, their top 3 in ascending order leading causes of death includes the cardiovascular and coronary conditions, again, heart disease and stroke. Secondly, hemorrhage. And then lastly, infection. So it's good for us to explore our data and analyze it and present it in a way, because we know that in some cases, one size does not fit all. We know that patient education and preconception health, a lot of those initiatives centered around physical activity and obesity, we know that those are one size fits all. But in some cases, there might be a more tailored initiative or a tailored activity or intervention to really speak to cardiovascular and coronary conditions or cardiomyopathy or even hemorrhage. What we do see is that in some cases, there is quite a disparity here as well. So we see that embolism, for one, we see that it's nearly twice as high for non-Hispanic Black mothers as it is for non-Hispanic white mothers. For preeclampsia, we see that it is more than twice as high for non-Hispanic Black mothers and then non-Hispanic white. And we see that for mental health conditions, we see that the percentage of those pregnancy-related deaths in the non-Hispanic white population is 11.3%. So again, mental health conditions, we're starting to see an emerging trend with mental health conditions. When we look at the distribution of pregnancy-related deaths by timing, we see that nearly a quarter of those deaths happen while pregnant. And then nearly a quarter of those deaths happen up to 43 days, up to 1 year postpartum. But the alarming thing is more than half of the pregnancy-related deaths actually occur either during delivery or immediately after the woman dies, so up to 6 weeks postpartum. And what we can really speak to here is the benefit of the postpartum care or the postpartum follow-up visit, which is where the mother can speak with her physician, her provider. She can, he can check, or he or she can check to make sure she's recovering well from labor and delivery. We know that postpartum depression, we have information on postpartum depression, and we know that that occurs in women. Also, the management of hypertension or her diabetes, or even just talking with her physician about some of her concerns or her care. And a lot of times that focus shifts to the baby, but we need to also continue to keep that focus on the mother, especially seeing that half of those deaths occur within the first 6 weeks. And again, we look at preventability by race and ethnicity. Overall, we're seeing that nearly 2/3 of all pregnancy-related deaths are actually preventable. And this is a report from the CDC, the 14-state report. For Hispanic population, it's 61.8%. For the non-Hispanic Black population, 63%. And for the non-Hispanic white, 68.2%. We even know that preventability varies by cause of death. So for instance, for cardiovascular and coronary conditions, preventability has been documented at about 68% or 65%. For hemorrhage, even higher at 70%. So 70% of all hemorrhage deaths can be prevented. So the work of the committee really speaks for itself. And what we really want to do is move into those recommendations and to really share those recommendations with the committees, with the groups and organizations that can make that change. And as a recap, South Carolina reports that South Carolina reports 55% preventability among pregnancy-related deaths. In the recent 2019 CDC publication, in the graphic that I just showed, nearly 66% of pregnancy-related cases were determined to be preventable. We've seen that minority women have a nearly 3-fold higher rate of maternal death than white women in South Carolina, and not only just in South Carolina, but in other states and jurisdictions. And the leading causes of death, we've also seen it varies by race and ethnicity. And then lastly, those maternal safety and quality improvement initiatives, or AIM, safety bundles, they are impactful. And South Carolina has recently launched the AIM campaign here in our state to really address the prevention and reduction in maternal mortality and morbidity. With all that being said, South Carolina has had wins. So the Maternal Mortality Review Committee recently hired a full-time nurse abstractor. Before that, the nurse abstractor was volunteering their time, but still very effective, able to abstract a ton of records. But now the committee has a full-time nurse abstractor as well as a part-time nurse abstractor. Recently, again in July, we were able to strengthen legislation to enable linkage to vital records for improved case identification. So just to give you an idea of what that burden is, right now we know that from the death certificate alone, that between 12 and 14 pregnancy-related deaths occur each year. But when we think about pregnancy-associated deaths as a larger umbrella, there are about 40 to 50 that occur in a full year on average. So we have quite a bit of catching up to do. And then lastly, South Carolina implemented central hosting of the data entry system, Maria, for standardized data collection and reporting. Just recently, we have fully migrated into CDC's system. So now that we abstract into their data entry system, they can easily use our data for reporting and creating these multi-state reports so that we can see what the status of our nation is as it relates to this topic. Next steps for the review committee is to identify funding. Again, we know that the Prevention of Maternal Mortality Deaths Act did allow the federal government to release dollars to states for maternal mortality work. South Carolina, unfortunately, wasn't one of them, But hopefully in the future, there will be other opportunities to where we can receive funding to really support this work. And through that, we can begin to not only look at pregnancy-associated deaths, but also those, pregnancy-related deaths, but also those pregnancy-associated deaths, and which are those deaths that occur temporally related to pregnancy. So this might be those motor vehicular crashes or MVCs or overdose deaths, and we can begin to develop recommendations even for women of reproductive age and not just those who are pregnancy, those who recently gave birth. Also, family interviews. What's missing in a lot of these reviews is the patient voice. So the goal is to incorporate information from the key informant interviews or families so that we can see and understand what may have happened from the patient's perspective. And we know that there are a lot of things that are not captured in the medical record. And if we're looking at it from through the lens of a provider, we don't really see, understand the social context or the social environment of their patient, if they had social support, if they had everything or access to things that they needed, if they struggled with transportation. In some cases, if they were in or were a victim of interpartner violence. Also, improving reporting of maternal deaths. Anyone can report to this email address at mmmr@dhec.ac.gov or dhec.gov. It is secure. Right now, we are still utilizing this email address. Again, we also have access to vital records. So we have been able to really increase our case ascertainment. And lastly, I'm working on a comprehensive report from the South Carolina findings that really explores additional maternal mortality rates by race and ethnicity, by the mother's age, by geographic place of residence, by timing of death. We do know that all those things are important. And also we didn't touch on maternal age. We know that younger mothers and older mothers are at increased risk for some of these health outcomes. So we would really like to explore that a little bit further. And you can contact us. So for any data related inquiries, you can feel free to contact our Bureau Director, Dr. Cobra Ektaderi, with the Bureau of Population Health Data Analytics and Informatics. Again, you can certainly reach out to me as the epidemiologist, and then our lead nurse extractor is Kimberly Jenkins. Thank you.
Portavia, thank you so much for that informative presentation. A lot of really good information, a lot of information for us to digest. We did have some questions, Portavia, in the chat box, so I'm just going to go through them. The first one is asking, how many months of pregnancy are reported by the hospital? For example, is a mother tested for pregnancy if she dies but is only 12 weeks pregnant? Mm-hmm. What is the baseline?
Yes, that has been brought up. So in some cases, we are missing mothers who were early in their pregnancy. So for instance, if they didn't have an official pregnancy test on file and they died maybe at 25 and we didn't know that they were pregnant, that would be a missed case. Also, for those pregnancies that may have resulted in a miscarriage or induced termination. So we don't have that information. However, we are exploring linking up with the data system, data team for South Carolina, which is the South Carolina Revenue and Fiscal Affairs. We can link with them and get their hospitalization data, which we don't have. So right now, we don't link with their data. We do share our vital records data with them, and if they have information, they will link it back with us. But there are some cases that don't meet the reportable definition for a pregnancy or a fetal demise, and therefore we don't have that information. So we, not only South Carolina, but other cases, other states and jurisdictions, we're definitely still going to miss some cases due to that very thing.
Yeah, one of the questions I was going to ask was around data collection and how do we improve data collection. So thank you for extrapolating on that a little bit. Another question is, how does lack of prenatal care factor in the death rates?
Yes, so the lack of prenatal care, so what I tend to think of is actually having that ongoing care with the physician. It could go back to management of current health conditions that a woman has. So for instance, hypertension. We know that preeclampsia and eclampsia affects the African American community more. So what that connection could be is that having that physician, that ongoing access or ongoing meet or appointment with the prenatal care provider can, monitor those things over time, their history, manage those health conditions that either the mother didn't even know she had. In some cases, we found that some of these mothers died and they didn't know they had a heart condition. So I would say that is the importance of the prenatal care visit, where the mother's care can be managed as well as the infant's care in utero.
Absolutely. And then another question is, on the evaluation tool, you said racism and discrimination is discussed, but is there also a tool they are using to measure it?
No, it's more subjective. This is a new facet to the committee decisions form. I want to say, so we have quarterly meetings in South Carolina. I want to say in our most recent meeting in June, we explored it. We need some more information on how to really utilize this to our benefit. But yes, we have begun discussing discrimination during the meetings. So some of the question has been, or we've changed, I guess, some procedures, and that includes, instead of presenting first on race and ethnicity, starting out with the condition or the synopsis of the woman's care first, and at the end present her race and ethnicity, because sometimes we begin to develop, ideas in our mind of what may have transpired in the situation or in the case based on her race or ethnicity that might not be as beneficial. So we try to start out with just listening to the story and what happened, and then at the end finding out what her race and ethnicity was. But as far as having some validated tool for discrimination, we don't yet have that, but we do regularly meet with the CDC for them to provide that TA on how to best work through discrimination, as well as even the preventability question, because again, it's more subjective in nature.
Yeah, thank you. And that was going to actually be one of my questions as well, was around the discrimination piece that was added. I'm glad to hear that it was added. Would love to understand if any of the reviewers bring any bias into it. So at least I think you said starting with the story, I think helps to minimize that.
Yes.
One more question. It's two more really. One is the person asking for a link to the legislation. I think, Portavia, this was the legislation that allowed the linkage with the vital records. So I think we can provide that at some point. And I have Ms. Simmons who asked this question. I think I have her email address. So I actually can get that to her.
Okay, thank you.
Yeah. And the last question is, are there any differences in rural hospitals and more urban/metro locations? Thinking about the facility and provider related factors in particular.
Yes, so that's a really great question. We have not yet explored urban versus rural. So we do know that due to access, there are issues that can stem from geographic area of residence. One being, again, access to nutritious foods. Even access to a healthcare facility, because we know that some birthing hospitals have closed across the state, meaning some women are having to drive longer distances just to get to a medical center or even a hospital. So we have not yet explored that, but we do plan to, as we continue to get more cases abstracted, then we can really explore even some of the geographic factors associated with this outcome. Also levels of care. And so, yes, we know that women that live in the rural areas of the state, South Carolina is largely rural, but definitely those women that live in the rural areas of the state have some barriers that may not be faced by those who live in the urban areas or the metropolitan areas.
Yeah, and I thought we're at our last question, but this last one I think is, we need to just mention this. And I'm not sure, Portavia, if you're going to be able to answer this, or if you can, that's fine. We perhaps hold it over for our next session where Kimberly Seals, our MCH State Title V Maternal and Child Director will be our presenter. She is asking, please name 2 initiatives that policy advocates should support that would be helpful to practitioners doing this work.
Yeah, I will say, when you say policy initiatives, I'm not really sure right now of policy initiatives that may be best suited for Ms. Kimberly Seals. But I do know that once we can really look into and assess these recommendations that have already been developed for the cases we have reviewed, that we can begin to link some of those recommendations and actions with policy. And so what we want to do is definitely explore that question and so many others that were presented today in the comprehensive report, now that we're getting more cases reviewed. But yes, that's a really great question.
Yeah, and perhaps again, I think if people have an opportunity to look at the report that the committee sent to the legislature, they do include some recommendations. So perhaps that might answer that question a little bit as well.
Yes.
But thank you again, Portavia, for your time. Thank you everyone for your questions and participation. Our next webinar is going to be next Tuesday at the same time. Our speaker will be Kimberly Seals, who's the State Title V Maternal and Child Health Director. And she is going to be following up on what programs and initiatives do we have in South Carolina that help to address maternal mortality. So information again is on our website about how to find information to next week's session. And then the following session on the 22nd will be the role of implicit bias in maternal mortality. And we are fortunate to have 2 really great speakers in our chapter as members, Dr. Coretta Jenneret and Carissa Tucker, who will be the speakers for that session. So we hope that you will join us. Kate, do you have any parting words around logistics? So if anyone was on the phone, perhaps maybe they should email me their email address if they're interested in CEUs. We know that they are still pending, but just so that we will have their information. Our email address is midscbna@gmail.com. So thank you all very much for joining us. Thank you for the great questions, the conversation, the discussion, and we really hope to see you next Tuesday. Have a great evening.
Thanks. Thanks, everyone.